So to start off, I want to just review the definition of food allergy to make sure we're sort of all on the same page about that. And then I'm going to talk a little bit about the recent National Institutes of Health, specifically the Allergy and Infectious Disease Branch, guidelines around food allergy. Those are just a couple of years old and remain kind of the standard document of reference that I want you to be aware of. We'll talk then a little bit about what's new in diagnosis and management and treatment. So by way of definition, first of all, this is to remind us that a food allergy is really one of a subset of adverse reactions to foods, which can include toxic and metabolic reactions, such as reacting to preformed histamine in spoiled food or having untoward reactions to caffeine or MSG, to non-toxic reactions. And those can include things besides food allergies like panic attacks or things such as lactose intolerance, to the immune subset of non-toxic adverse reactions to food, which is really what we're talking about when we talk about food allergy. Even within that narrow definition, most of what we think about when it comes to food allergies and what most of your patients will present with are IgE-mediated food allergies. These are characterized by their dependence on this allergic class of antibody and are associated with immediate reactions. There is another class of food allergies that are non-IgE mediated that I'm not really going to touch on today. So a food allergy from that NIAID consensus document is defined as an adverse health effect arising from a specific immune response that occurs reproducibly on exposure to a given food. And there are a few key concepts in there, including the fact that it's an immune specific response and that it's reproducible, that are helpful when we think about and evaluate the history of someone presenting with an adverse reaction to a food. Here are references to those guidelines that I mentioned, and they are available not only in summary form for clinicians, but also, not shown right here, summary for a lay audience, and can be very helpful as a resource to your patients if you wish to send it to them. The rationale for the NIH convening this consensus panel is highlighted here. It was recognized that food allergy is now affecting 5 to actually even 8% of young children, and a significant percentage, as much as 1 in 25 of older individuals. And NIH identified, based on this high prevalence and apparently rising prevalence, the need to harmonize best practices. And this whole process began all the way back in 2008 during a time with leadership from the American Academy of Asthma, Allergy, and Immunology. And the goal was to provide concise guidelines for a wide range of health providers on how to diagnose, manage, and treat acute reactions. And as I said before, it still remains the definitive source for much of that information. The secondary goal was to help us really, as a field, identify gaps in knowledge. So the American Academy, as I mentioned, lobbied NIAID to sponsor the development of these guidelines. NIAID then formed a coordinating committee with representation from a wide range of groups, including professional societies and patient advocacy groups. And the process then was for the coordinating committee to really oversee the guideline development, to advise NIAID on their development, to establish an expert panel that would actually write those guidelines, and to review and approve the final draft, as well as aid in its dissemination. So it started off with a literature review. Part of that was actually outsourced to the RAND Corporation. There was, from that literature review, the preparation of evidence tables, and the expert panel drafted the guidelines, drawing on that literature review, but with the opportunity to supplement sources to that, as well as add their own opinion. And there were a number of consensus areas identified, as well as knowledge gaps that I'll review some highlights from those. So there were, in fact, more than 12,000 articles screened from 1988 up until the very end of 2008, early 2009. From those, 900 articles were ultimately abstracted, and 350 were included in the final report. This literature review itself was published in JAMA in May of 2010, and is a very helpful document if you just want to sort of get a primer on current literature in the field. The evidence was ranked according to quality as follows, so either high, moderate, or low, from things that were unlikely to change even with further research to things where further research was very likely to have an important impact on the body of that evidence. The panel was chaired by Joshua Boyce here in Boston at Brigham and Women's, and as I mentioned before, really broadly represented specialists from a wide spectrum of medical disciplines that see these patients predominantly, including, of course, allergy, but also including GI, emergency medicine, epidemiologists, dermatologists, et cetera. And the guidelines were broken up into 5 topic areas, and each of those were chaired by the individuals that you see here. The expert panel drafted those guidelines. They were actually within those 5 topic areas, a total of 43 guidelines along with supporting text. But very importantly, along with the recommendation was information provided on sort of the strength of that recommendation. So the recommendation could be strong or weak, but the strength of the recommendation was independent from the level of evidence. So one could have something strongly recommended, like using epinephrine for anaphylaxis, even in the presence of relatively weak data, sort of in the spirit of we don't need double-blind challenges to prove the efficacy of parachutes for skydivers. So the process undertaken by the expert panel was really one of consensus building. So there was open discussion of each recommendation and revision, followed by panel-wide voting in an iterative process such that by the end of the second round, all guidelines with at least 90% consensus were included in the draft for public comment. There was only one recommendation that failed to reach that consensus level. So I've already excerpted from the definition here, but in section 2 is really where we cover sort of definitional aspects, and so here is where we find definitions such as what is a food allergy that I mentioned before, but also what is the role of skin testing. So here I think important to note, as I've highlighted in the green text, that skin testing and other evidence of specific IgE, such as serum tests for IgE, commonly called RAS tests, may be responsible for IgE-mediated food reactions. But very importantly, a clinical history is needed, and when indicated, an oral food challenge may be necessary to confirm the diagnosis. So the expert panel recommends that a food allergy should be considered in individuals that present with anaphylaxis or any combination of symptoms that I'll show in Table 1 or that are present in the document, occurring within minutes to a few hours of ingesting a food, especially in young children, and or if symptoms have followed the ingestion of a specific food reproducibly. Remember, back to that definition, that a immune-mediated reaction to a food allergy, is both specific and reproducible. In infants and young children and some older children with IgE-associated disorders like eczema or eosinophilic esophagitis, food allergy should also be considered, as well as in adults with eosinophilic esophagitis. Here's that table of symptoms that I mentioned that would be supportive of the diagnosis of a food allergy, and they include really much of what you would expect in terms of skin findings of hives or itchiness or erythema, to respiratory findings in the upper or lower tract. So what's new in diagnosis? If there was nothing else that I want people to take away from an introductory talk on food allergy, it really should be this, that sensitization does not equal food allergy. And so you might wonder, why is there so much specific IgE when we do testing? Prevalence of sensitization is far in excess of the prevalence of true clinical food allergy, and it's often discordant. Exposure can modulate the risk differently for sensitization, which is the jargon term we use for the presence of detectable IgE. That can be either by skin test or by serum testing, and clinical food allergy. IgE development or production appears to be, to some extent, normal in the early development of the immune system. And there's evidence that immature B cells more readily differentiate into IgE-producing cells. And that IgE may be of lower affinity and yet still be detected with routine tests. And that's because, in part, current testing really has a large excess of antigen and is very, very good at detecting even low affinity binding IgE antibodies. So it's very permissive. There are new tests commercially available now that, rather than looking at IgE antibody to an entire extract of a suspected source like peanut or milk, uses instead defined allergens from those sources, and has been shown in some cases to have greater specificity and is hoped to provide greater risk stratification, although that remains an area of active research. So here's one example of how this so-called component testing can improve the diagnosis of peanut allergy. You can see here in green is skin testing with a large area under the curve. So this is ROC curve analysis, and this red line represents the test performance for ARIH2 detection, while the blue line is the traditionally used serum whole peanut test. And so you can appreciate that this serum test has comparable performance to the skin testing, and both of these have much better performance than the standard IgE testing. And when used in combination in a population of patients with a given pretest probability, one can greatly reduce the number of individuals who are falsely classified. So we improve the specificity such that by adding this step of ARIH2 specific IgE testing, you can reduce the number of oral food challenges that are necessary to correctly diagnose patients in the case of peanut. And yet there are discrepancies. So in another study looking at the performance of component testing, again in the context of peanut allergy, this time in a population that had very high prevalence of birch allergy, we find some examples of individuals with severe reactivity to peanut allergy, true clinical allergy, and yet no detectable IgE binding to those component allergens, including ARIH2. And similarly, we find individuals who do have detectable ARIH2 specific IgE antibody in the absence of systemic clinical reactivity. And so even the use of these component diagnostic tests still results in a significant degree of misclassification, as we can see here. These are individuals that have intermediate binding to ARIH2, and yet some of them have symptoms suggesting systemic reactivity. Furthermore, there are already known to be important geographic differences in the performance of this test. So in some populations, the prevalence of antibody to a component like ARIH2 is very high, such as here in the US, while the prevalence to one of the cross-reactive components, ARIH8, is intermediate in comparison to, say, Scandinavia. Here in Boston, actually, this is pretty high, but in other parts of the US, it would be low. And in other parts of the world, similarly, there's variability, and that affects how well these tests work. But here's the case to sort of illustrate how these can be useful. So recently saw this 7-year-old boy with a history of suspected food allergy at 3 years of age when he had a few hives after eating some birthday cake. He had never knowingly ingested peanuts, although there was suspicion that there were nuts that he was exposed to at that time. Testing was positive to peanut extract using the traditional test, along with some tree nuts and sesame, and he avoided everything ever since without any additional exposure history to help us with the diagnosis. So he had experienced signs and symptoms of spring hay fever or allergic rhinitis for the past few years, and that was easily controlled with just oral antihistamines. So this is the test results for this patient. Skin testing showed pretty strong reactivity to peanut with a 10 millimeter wheal reaction. The predictive value in most population studies as a whole would suggest that greater than 8 millimeters has a strong positive predictive value. And he also had sensitization to other nuts as shown here. Furthermore, his peanut-specific IgE in the serum was 10 kilounits per liter. Again, a level that would be associated with true clinical reactivity in more than half of patients with his age and background. However, the component-specific testing revealed no detectable IgE to any of the major allergens from peanut and very high detectable IgE to the cross-reactive component ARIA-H8. And so on the strength of that evidence, we performed an oral food challenge, and in fact, he had no symptoms at all and was able to add peanut back to his diet. The problem, however, is that what people often think that they will learn from this sort of testing is something about how sensitive they are or how severely they may react. And current data does not support that. So while this test specifically for peanut allergy improves the specificity of diagnosis, and that's why it won approval from the FDA, it really doesn't give us insight into reaction severity. There are other things on the horizon, including additional platforms for components, so other foods that will be tested this way, and functional tests that look at the reactivity of a specific type of white blood cell, basophils, to improve diagnosis as well. But those are still at research stages. So moving on to what's new in management for food allergy. Here, the expert panel recommends that individuals with documented IgE or non-IgE mediated food allergies should avoid ingestion of their specific allergens. That's probably not so surprising. But there are cases where the diagnosis is less clear and where one, given what I've just been talking about, the lack of specificity of IgE testing, it's necessary to be prudent about what testing is done. So the expert panel suggests that children under 5 with moderate to severe eczema be considered for food allergy evaluation for major allergens if standard treatment for eczema fails, and if the child has a reliable history of an immediate reaction following the ingestion of a specific food. But the expert panel does not recommend restricting the maternal diet during pregnancy or lactation as a strategy for preventing the development or changing the course of food allergy. And the current recommendation is that we have insufficient evidence to recommend routine food allergy testing prior to the introduction of highly allergenic foods in children who are thought to be at high risk. So for example, a sibling of someone who's food allergic. Nevertheless, in those kinds of cases, the EP recommends that it might be appropriate to delay the introduction of those to some extent. However, many of you are probably familiar with recommendations now going back a few years that things that are thought to be highly allergenic, such as peanut and shellfish, be delayed until 3 years of age, or egg until 18 months. Those recommendations have all been rolled back, and there's no longer any specific recommendation to restrict foods early in life for reduction of allergy risk. Management otherwise then really relies on appropriate treatment of accidental reactions if they occur, and that really comes down to the use of epinephrine for cases where there's thought to be any multi-organ system systemic involvement or airway involvement associated with the ingestion of a food. And those are listed here and available in the guidelines. There is a new FDA-approved epinephrine auto-injector on the market, but fundamentally it remains the case that avoidance and having an action plan for accidental reactions remains the standard of care for current. What's most lacking then in management? I would say that really risk assessment. What my patients most often want to hear, and which we're inadequately equipped to answer, is how allergic is their child? How dangerous is the food allergy? What are the dangers, in fact, in the environment? And what is appropriate from a public health perspective? And I think we have to ask the question of ourselves of whether or not we're feeding hysteria. And I want to reach out to the primary care community to be our allies in this regard. So We have one study that we're participating in to help address this sort of question. It's called the Peanut Allergen Threshold Study. We're recruiting almost 400 allergic individuals in the pediatric age range. It's a multi-center study here in Boston, in Ireland, and in Australia. And the goals are really to ask whether or not by giving a single low-dose exposure, we can stratify children with respect to risk for reactions and reaction severity to peanut. And furthermore, by doing this challenge maneuver, can we also identify biomarkers by blood testing that are tightly correlated with that risk? There is, at this point, no recommendation for using allergen-specific immunotherapy to treat food allergy. So it still remains the case that the number of participants that have gone through well-designed studies of this nature are small, measured in dozens to hundreds. Safety data are generally good, but systemic reactions certainly do occur, and they're not easily anticipated. We really don't have a handle on picking the people who have better outcomes or higher rates of adverse events. And those outcomes really need to be qualified. So here's one example of why I want to emphasize that immunotherapy is not ready for prime time. This was a meta-analysis of several randomized controlled trials for the use of immunotherapy in cow's milk allergy, and they did indeed show that there was a 5-fold increased risk ratio in favor of passing a post-treatment challenge. So after treating people for the better part of a year, they were able to tolerate more milk on challenge than they were before that. However, the same study identified about a 5-fold increased risk of requiring epinephrine that was associated with treatment. So patients who participated in these trials were 5 times more likely to need to use their epinephrine auto-injector than people who were simply avoiding milk and following standard of care. And given that we still don't know what the long-term benefit of immunotherapy after it's stopped on a daily basis, I think we have to weigh that adverse event potential carefully against the perceived benefit. This was another meta-analysis, this time focused on peanut allergy, published in 2012. Similar conclusions, 6 studies with a total of 85 participants. They concluded here, to summarize, that particularly when thinking about the longer term, there needs to be much more done to establish efficacy. And lastly, in a study conducted by the Consortium for Food Allergy Research and funded by the NIH, these authors attempted to look at that question of prolonged or persistent benefit after the cessation of therapy, and they found in the end that 28% of the treated individuals achieved a level of persistent protection from egg exposure, so less than a third. There are other desensitization therapies being evaluated, including the application of a patch to the skin and exposure of allergen through the epicutaneous. In fact, there is one late phase 2 study that was just published in September, or results were released rather in September, that looks optimistic. So in that case, 2/3 of participants achieved the primary outcome of tolerating more in post-treatment challenge than pre-treatment. However, it still remains to be seen whether that benefit will be persistent and whether it's high enough to prevent real-world exposure reactions. There are a number of novel treatments in various stages of research, including a large multi-center OIT trial, the combination of anti-IgE with oral immunotherapy, or transition from sublingual immunotherapy to oral immunotherapy, and others, but they remain really in research stages. So let's not forget about good management. So focus the testing on the history that you have. Don't overdiagnose food allergy to begin with. It's so often the case that all I'm doing in clinic is adding foods back to patients who are never actually allergic to them but were only sensitized. Help patients contextualize the real risks. I'll talk a little bit more about that in a second. Understand the limitations of the testing that's being done, and refer people out to credible and well-evidenced sources of support, including from the Food Allergy Research and Education Foundation and others. Here's a little bit about that risk contextualization. So patients, understandably, are very, very worried about the risks to them if they have a food allergy. This was a very nice study published just in 2013, putting that estimated risk for people who are diagnosed with food allergy into the context of other life accidental and other event risks that we all face all the time. And as you can see here, even for people with a diagnosis of food allergy, the fortunate news is that severe events, including deaths, are very rare. So this is a very common disease and with a very, very low mortality rate. And it's important for people to understand that and understand what they can do to reduce their risk. So what I want you to take away from this talk, first and foremost, is that a positive IgE test, that is sensitization, does not equal clinical allergy. That component testing looks like a very promising new diagnostic method for improving the specificity, but its interpretation will still require clinical expertise, careful history taking, and often food challenges. That risk stratification remains one of our still most important unmet needs, and that immunotherapy for food allergy really is still a research methodology. It's not ready for current treatment.